Hi there. Welcome to the first in our series of videos for your prenatal education. My name is Kim, and we have about 9 videos in this series that can help take you through your entire prenatal education. We thought we'd do this given that many hospitals have gotten rid of their in-person classes at the moment, and with not being able to necessarily venture outside, all of our time sort of being juggled around right now as well, we thought that this would be a great opportunity for us to create for you a video series to be able to watch at your leisure and to come back to when you need to, particularly for the postpartum and breastfeeding, chest feeding side of things. So we've created this series and let's get right into it. We're calling this particular one At Your Cervix, Weird and Wonderful Facts About Your Body During Pregnancy and Birth. So let me introduce myself first. My name is Kim Fernandez and I'm a prenatal teacher. I am also a certified labor doula and a postpartum doula, and I have been so since about 2006. I am the mom of 3 amazing young adult humans who are wonderful and brilliant and smart and funny and keep me on my toes. And I couldn't be prouder of them at all. I also have 3 fur babies as well, and I'm hoping that maybe they'll stay quiet enough for me to do this. I am also the prenatal teacher, one of the prenatal teachers at St. Mike's in Toronto, and have been teaching classes there for a number of years now. I'm also, as I say, a certified labor doula, postpartum doula as well, and have been so since 2006. And I also host a podcast with 2 of my doula sisters called the Pragmatic Doulas Podcast. It is available on most podcasting platforms. However, it does have a little bit of cursing in it. So if you are a little bit sensitive to that, it may not be the podcast for you. It is mostly geared toward doulas, but it also has a lot of information about birth and pregnancy and postpartum and breastfeeding and all of that stuff. So feel free to check it out, but again, not for sensitive ears. So there are handouts for this session, and you can find them on the torontodoulagroup.com/anatomy-handouts. These handouts are on a password protected page, and you will have to type in the whole web page. The password is anatomy with a capital A. And I encourage you to print them out as well, so that you can take notes. You can pause me here if you want and check it out, print those off and then use them. There's, as I say, there's space for notes and whatnot, and not everything I say is going to be in there, but you might find it helpful to take notes as we go through. So in this session, we're going to learn to identify the various body parts of the pregnant body. We're going to talk about everything that is going on inside there and why it's important for your pregnancy and pushing and birth. We're also going to learn maybe some tips and tricks to use during your labor and delivery as well. So as I say, I encourage you to print those handouts out so that you can take some notes. So let's get started. We're going to talk first about the fundus, and this is the top portion of your uterus, and your care provider, as you get close to the end of your pregnancy, may be measuring from the top of the fundus to the top of the pubic bone. And in theory, this should equal in centimeters the number of weeks pregnant that you are. Now, it can be off by a centimeter or 2 either way. That's not a big deal. But if you're measuring large, they might be concerned that perhaps you have too much amniotic fluid, which can be a hindrance during the delivery stage or your labor stage. It can also, if you're measuring small, they might be concerned that maybe baby isn't getting everything that they need from the placenta or the cord. So odds are with either large or small, they'll probably do some ultrasounds to just make sure that everything is going well with baby and that everything is good in there. Now, the amniotic sac actually grows out from the placenta, and that is a clear membrane that is going to hold in baby and all of that amniotic fluid. I'll talk about the fluid in a second, but at some point in your labor, your waters may break. Now, in Hollywood on television, the waters break 100% of the time to tell you that labor has started. That's how you know the main character is in labor. They're basically standing in a puddle of water. In real life, that actually only happens about 10% of the time. So your waters breaking probably isn't going to be the first thing that you notice. It will probably happen at some point during your labor. We will talk about in one of the next sessions we have on medical interventions, we'll talk about amniotomies and medical staff breaking your waters. So definitely want to tune into that one. Now the placenta is amazing. How cool are we? We grow human beings. You give us a little bit of schmutz, and from it, we grow an entire human. And from that, we are going to, in order to support this human, we're going to grow an entirely new organ, and that happens to be the placenta. When the placenta is actually going to transfer nutrients, hormones, oxygenated blood, all of that to baby, but it will also filter out for baby all their waste products so that your internal organs will deal with them. The placenta, however, is no filter at all. So anything that you consume that does go to your bloodstream will go to baby. So your care provider in the beginning will likely have been cautioned you about particular medications, smoking, alcohol, recreational drugs. These are all things that can go to baby and can potentially disrupt or hinder their growth. So be careful with things like that. When the baby is born, the uterus will actually start to shrink down and the placenta won't be able to hold on any longer and will pull away from the lining of the uterus. And after baby's born, maybe anywhere from 10, 15, 20, 30 minutes afterwards, you may have to give another little grunty push to get the placenta out, but it won't be anything like what you had to do to get baby out. You'll be so engrossed as well with baby that you probably won't even remember this part. When it comes out, the care provider will have a look at it, make sure that it's all good and healthy, and then it usually goes to biohazardous waste. You do have the potential, however, to keep it, and some people will keep it and either bury it in a ceremony, or some people will keep it and create placenta capsules with it. And these can be helpful in hormone, lessening that hormone drop that you have. We have at the Toronto Doula Group, we have a doula that specializes in this. So if you have more, or if you would like to have more information on it, you can always contact us at support@torontodoulagroup.com. Now, the amniotic fluid is a clear, odorless fluid. Some people say it often smells sweet, but it actually shouldn't smell at all. And it actually is helping to cushion baby. It is helping with temperature control as well. And baby also right now is breathing it in and breathing it out to practice their breathing. They're also swallowing it and peeing it out to make sure those are all working as well. So that's quite cool. When your waters break, it's important to note that they are clear. If your waters break at home and they are not clear, if they are greenish or brownish in color, we want you to make sure that you're contacting your care provider as soon as possible. What this means is that babies had their first poop on the inside. So as mentioned, they do pee on the inside, but they don't poop on the inside. They save that for you. Now, what it could be is, it could be that at some point, baby was under some type of stress. It doesn't mean that they're under stress at that moment, but at some point that they were, and that's caused them to have a poop. However, it could also mean, especially if you go to that 40-week date or beyond, it could also mean that baby's just starting to function. Their system is coming online and they're starting to work. So in that case, then it used to be that if you had meconium, it's called meconium. If you had meconium in the waters, it used to mean that it was an automatic cesarean birth, but that isn't the case anymore. If there are meconium in the waters, what will happen is they'll monitor you a little more closely to make sure the baby is good and healthy, but you'll be able to deliver vaginally. And there will be, however, an extra person in the room when you deliver, and that will be somebody from the neonatal unit, pediatric unit, either a pediatrician or a pediatric nurse, a neonatal respiratory therapist, somebody who will come in just to make sure that baby hasn't inhaled any of this junk when they take their first breath. So a lot of times what you might see is that in videos, they do a lot of suctioning of babies, but in Toronto and Ontario and Canada, we don't do a lot of suctioning of babies when they come out. We actually just let them cough and sneeze and spit and do all that stuff on their own. But if there is meconium in the waters, they will do some suctioning again to make sure that they don't inhale any of it, because it can actually cause an infection. Now the pubic bone is sort of baby's limbo stick, what they have to get under to get out. So my trusty pelvis here. So what is supposed to happen with baby? Babies are supposed to come into the pelvis, come out from underneath the pubic bone for pushing. And the longest part of pushing is going to be to get baby's head molded and to get that underneath the pubic bone. So that can take a couple of hours in order to do that. So if pushing is taking a while, that's not a problem. The best pushing positions are going to be something that is more upright, forward leaning. If you have an epidural, it may be in a semi-seated position or potentially be on your side, which can also create some space there. We never have you pushing flat on your back because that's kind of stupid. At worst, it would be in that semi-seated position, which is very common and you may have seen in Hollywood shows. Now the bladder, as you can see where it is in relation to baby's head, it needs to be emptied on a more regular basis. So one of the tips for your partner during labor is to make sure that you are peeing repeatedly through the labor itself. Well, why do I need to be reminded? Well, there's so much going on down here that the I gotta pee message doesn't always make it up here. So make sure that your partner is getting you to go to the bathroom continuously throughout the labor, because if not, if that bladder is full, it's going to prevent baby from moving into the vaginal canal, and it's also going to cause contractions to be a lot more intense. And we would like to lessen those if we can, right? However, keep in mind, you will actually have to fill that bladder up. It's very easy to become dehydrated in labor, so it'll be important to make sure that you are taking sips of water and juice and other things throughout the labor itself. We talk about sort of what to eat and drink in our session on medical procedures as well. So again, probably a good one to watch as well. Now the vagina, for many, this will be the out. This will be where baby's going to come out. It is a very stretchy area, and baby will, again, their head will mold and everything will stretch for baby to come out. And it will go back to its pre-pregnancy state. Sex after you have a baby is not different because your vagina is all stretched out. It's different because there's now a baby there all the time. And even when that baby is off at a sitter or somewhere else, it lives in your head. So you always sort of have that baby in your brain. So make sure that when you are getting to that point where intercourse is coming back into your relationship, because we really want to keep everything out of the vagina for at least 6 to 8 weeks after baby comes out of it, all right? So nothing goes in there until about 6 to 8 weeks afterwards. When it comes time for that, make sure that everybody's on the same page. Have those open, honest, respectful conversations about where everybody is in the process of getting back into sex. So now the rectum, the other side of the coin, we grow humans, we grow organs to support this human. However, we're not going to grow new muscles to push this human out. We're actually going to use your rectal muscles, and because they're right there. And because of we're using your rectal muscles, when it does come time to push, you'll actually feel like you'll have to have a bowel movement because baby will really be sort of sitting on your rectum and putting lots of pressure into your bowels. So as you get close to the end and you start to feel that, it'll be important to make sure that you let the nurses know or the midwives know so that they can check and make sure that it is time to push. And when you do push, you're going to push like you're pooping out your baby. That's it. You're going to push like you're pooping. Well, then comes the thought of, oh my God, am I going to poop on the table? Yep, you might. Suck it up, buttercup. It might happen. However, there's a couple of things to remember is In early labor, when you're getting ready to actually go into labor, your body's actually going to cleanse itself. It doesn't want to have to deal with all that stuff either. So you'll actually get loose bowels. You might feel like you've eaten something bad, or you'll get the flu, feel like you have the flu, and your body's just going to cleanse itself. Then by the time you get to active labor, you're probably not eating because everything is sort of really happening at that point. And so as a result, by the time you get to pushing, there probably isn't anything there. And if there is, it's usually just a small amount. And it isn't like the nurse or the midwife are going to sit there and go, oh my God, look at that, that's so gross. They're just going to discreetly wipe it away and nobody will be the wiser. And if you know it happened, no problem. If you didn't know it happened, that's okay too. One thing I want to caution you though, don't try to hold back from pushing because you're afraid to poop on the table, because if that happens, then what will likely happen is they're going to help you get your baby out. And that help could come in the form of a vacuum extraction or a forceps delivery. So you definitely don't want to hold back on pushing, just push. And let's be real, as soon as this baby's born, your whole life is going to be about poop. So you might as well get used to it. Now, the perineum is the space between the base of the vaginal opening and the rectum. And in your handouts that I have given you, that I've encouraged you to print out, there is a article on perineal massage. Now, the perineum, if there's going to be any tearing, this is where it's going to happen. So as baby comes down, it'll stretch the perineum, and sometimes it'll get to a stretching point where it's just not going to stretch any further and you'll get a bit of a tear. First time parents, birthing parents, it's not uncommon for you to tear, which is totally fine. Ways to try and reduce that tearing is, again, you can do some perineal massage before you actually go into labor. And that can help. If you think about it, the perineum is a muscle. And if you went and did a workout without stretching first, you could actually injure your muscles, correct? You might pull something. Well, it's kind of the same idea as this. Perineal massage is almost like that pre-workout stretching. It's almost like yoga for your perineum. So what you're trying to do is actually make that muscle more stretchy, more pliable, not loose, but more stretchy and more pliable, so that when it does have to stretch further than what it has in the past, it will actually do it. So that can happen before labor starts. And especially if there's an epidural, during the pushing stage, the nurse will usually do some stretching of your perineum and whatnot as well. So they'll put some pressure down there and stretch out as well, okay? And that will be helpful too, because they'll put that pressure that they feel, you'll be able to feel it, and then you'll push against that pressure. And that's helpful when an epidural is in play. Trying to, again, as I mentioned, pushing in a more upright position, either semi-seating, sitting upright, or forward leaning, or even on your side, can help take some of that pressure off your perineum and create an easier movement of baby through that area. And trying to push on with the contraction. So sometimes if you watch Hollywood, the pushing looks completely ridiculous and random. It's like, oh, talk, 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 I love you, blah. And then they're pushing and people are screaming and yelling. It doesn't really work that way. Pushing in real life really looks more like, as the contraction is starting to build, you'll bear down with that pressure that you're feeling and push against it for maybe a count of 6 to 8, maybe 10 if you can. And you'll do that 3 times within a contraction. So you'll probably have 3 pushes. And as that happens, baby is going to come down a little bit more and then scooch back up, and then come down a little bit more and scooch back up. And we want to get 3 so we can get a little bit more and scooch back up. And as that happens, everything is stretching and stretching and stretching and stretching. And that, again, allows for easier stretching and less likelihood of tearing. If we're trying to rocket this baby out, then yeah, there's no time for the tissues to stretch. So it's nice if we can work. Pushing can take a while, and that's a good thing, so that everything can come down and be, stretching nicely the way it's supposed to. All right. Now the cervix, right now your cervix is probably about that long, sitting a bit further back, and it's actually quite firm like your forehead. What will happen as you get close to actually going into labor? So even before labor starts, the cervix will actually start to soften, get squishy, and even thin out a little bit. So eventually we want it to be not firm like your forehead, but it'll get a little bit softer, and then it'll eventually get really soft and squishy and stretchy like your cheeks. And that's what we're shooting for. And then when that happens, everything can stretch. We're ultimately wanting that cervix to stretch open to be about 10 centimeters dilated. That's the magic number with 10. The funny thing about that is, though, is it's kind of an arbitrary number. It's kind of just an estimate. If your baby's head is bigger than 10 centimeters in circumference, it's going to have to get bigger than 10. But if your baby's head is smaller than 10 centimeters in circumference, it doesn't have to get to 10. So usually what you'll see when you get to the end is they'll do a vaginal exam and they'll say you're fully. Okay? They won't say you're 10 centimeters, they'll say you're fully. And all that means is around the widest part of baby's head, there's now no more cervix for the rest of the baby to come through. Okay? Now this is where things can get a little bit confusing when it comes to early labor. The mucus plug. The mucus plug is really, the cervix is corked with a chunk of mucus. And that buildup of mucus helps protect the cervix and the baby really from infection. But as the cervix, as I mentioned, is starting to thin and open slightly, the mucus is being held in there with pressure. So as a result, it will dislodge because it's not being held in there with pressure anymore, and will come away and fall out. Now, if you're a first-time birthing parent, odds are that when that mucus plug falls out, labor is still days to potentially weeks away. If this was your second baby, it's usually mucus plug, labor right away. But with first-time birthing parents, it's usually mucus plug, then some other stuff happens, some crampiness and things like that. And maybe a few days later, labor will actually start. Or the crampiness could happen to dislodge the mucus plug, and then everything settles down for another week or two. So if you see the mucus plug, it's not time to go to the hospital yet. Okay. It is just one of those steps that has to happen in preparation for labor starting. Now, it's usually about the size of your palm. It's not the inside of your palm. It's not a super amount. And for some, it will come out in one giant chunk. For some, it'll come out little bits at a time. For some, it could just be like an overproduction of mucus, just very stringy mucus. Sometimes you could see it tinged with blood, which is normal. And that bleeding is actually coming from the cervix itself. As the cervix is starting to thin and open, blood vessels are breaking. So that's where the bloody show or the bleeding in labor comes from. The other thing too is to remember is that just built in behind the mucus plug at the top of the cervix, between the top of the cervix and the amniotic sac, is a very thin layer of really watery mucus. So sometimes if the mucus plug comes out in one giant chunk, what will happen then is you might feel a little trickle of fluid, and it might feel like maybe your waters are broken. Okay, if it really is your waters breaking, it will continue to trickle throughout the labor. So anytime baby moves, even though baby's head is going to cork the top of the cervix when your waters break, every time baby moves, then little trickles of fluid will come. If it's just a one-shot deal, just that one little trickle and it doesn't happen again, that's all it was, okay? Or if you can stop the flow with a Kegel, it's pee and you just peed yourself. So keep that in mind. If you feel that trickle of fluid, just wait and see if it happens again after maybe 20 minutes or so. If it does happen again, then yeah, it probably is your waters breaking. But before that, don't rush out to the hospital if that's the case. You may not actually be in labor yet. Now, the umbilical cord is going to, again, draw oxygen and nutrients and hormones and everything into baby, and it's going to get rid of baby's waste products. The amount of cord that's in there is potentially about 3 feet for some of you. And if I'm not mistaken, baby's auditioning for Cirque du Soleil. So it is actually quite possible for baby's cord to be around their neck. And that's not necessarily a bad thing. Not necessarily a good thing, but it's not necessarily as bad as we might make it out to be, or what Hollywood might make it out to be. So as long as that cord, even if the cord is around the neck, we have to remember that isn't how baby's breathing. Baby's actually breathing through the cord. So as long as that remains free flowing, then we're all good. The only time it becomes a problem if maybe it's a couple times, or if it's wrapped around something that's preventing baby from moving down, or if it's being pinched in some way. So if that's happening, then baby's actually going to tell us. So if you haven't been monitored continuously through the labor itself, you will be monitored through the pushing stage so that we can see how baby's tolerating pushing. As baby's head comes out, the care provider will actually feel if there's cord there, and then if there is, they'll move it out of the way, and then the rest of the baby comes. Okay. So partners, if you do notice that the cord is around baby's neck, don't panic. It's actually not as uncommon as you think. And when the baby comes out, they will clamp the cord in two places. Many hospitals nowadays are doing a 1 minute delay of cord clamping. And we know that doing that can help get that blood back to baby. If you wanted it to be longer, you absolutely could. We talk more about this in the session on baby's first 24 hours. So again, I encourage you to check that one out as well. Almost done. So the spine, this is that's where the epidural is going to go. And it also, as I mentioned, baby's going to come into the pelvis and they're going to turn and face your back. But sometimes their GPS is a little bit off. And when they do, sometimes they come in and they actually can put extra pressure onto the back of onto your tailbone and your skull if they're facing your front. So when that happens, it's called back labor and it's very uncomfortable. So trying to choose positions for labor that are going to be more upright, forward leaning will be very helpful to get baby into a more optimal fetal position. I do encourage as well too, we have a session on medical pain management and epidurals, and we talk about sort of how to manage your positioning and whatnot if an epidural is involved. Because when an epidural is involved, you no longer have those upright forward leaning positions. So we give you some tips and whatnot in there to encourage baby to stay in a good position, at least throughout the rest of the labor. Now, the uterus is a very cool part of your body. So it starts out this big, and then it's going to get this big as it grows with baby. And it is a muscle. It's actually a group of 3 muscles. And the outer layer of muscle fibers are long like this. And the middle layer supplies blood to the inner and the outer. And then the inner muscle fibers are actually circular in nature and concentrated close to the bottom. So what happens in a contraction is those long muscle fibers squeeze together, and at the same time, we'll pull those circular muscles up around baby's head. So that's how a contraction works. Squeezing together and pulling up around baby's head. That's all a contraction is. And like any other muscle grouping in your body, it works. So you will, after the baby is born, the uterus isn't going to go back to its pre-pregnancy state right away. It will take about 6 to 8 weeks to get back there. So you will look about 4 to 5 months pregnant when you leave the hospital. So it'll be important to make sure that you are wearing nice, comfortable clothing when you go and when you go home, and just get into bed when it's all over and done with. We do talk about your postpartum recovery and the bleeding and all of that stuff in our session on postpartum recovery. So if you want to learn any more about that, I suggest you check that one out. So that's it for our body parts. What I recommend is if you enjoyed this, absolutely check us out at torontodoulagroup.com and look up our video series. This one we are offering for free to give you a bit of a taste as to what my teaching style is like. And you can follow us on Instagram and Facebook as well. If you have any questions about this particular session, about any of the sessions really, or if you need more clarification on something that was said, please feel free to email us at support@torontodoulagroup.com. And as I say, we do hope that you will check out the rest of our series, and we hope you enjoyed this. Have an awesome day.